Welcome back to Ellie Scrubs In. In this video, we'll walk through the laparoscopic splenectomy, a minimally invasive procedure to remove the spleen for a variety of hematologic and traumatic conditions. While open splenectomy still has a role, especially in emergencies or when the spleen is massively enlarged, the laparoscopic approach is now preferred for most elective cases due to faster recovery, less post-operative pain, and shorter hospital stays. Let's walk through the key steps, instruments used, surgical pearls and pitfalls, and post-operative considerations. Let's scrub in. Step 1. Indications and pre-operative preparation. Common indications for laparoscopic splenectomy include idiopathic thrombocytopenic purpura, ITP, hereditary spherocytosis, autoimmune hemolytic anemia, and splenic cysts or tumors. Occasionally, it's performed for trauma in stable patients, or as part of a cancer staging procedure. The patient is vaccinated preoperatively against encapsulated organisms, Streptococcus pneumonia, Haemophilus influenzae, and Neisseria meningitidis. The patient is placed in a right lateral decubitus position, with the left side up to allow the spleen to fall away from the retroperitoneum. The table may be flexed to increase space between the costal margin and iliac crest. Pearl. Ensure proper positioning and padding to protect the brachial plexus and prevent pressure injuries during this lengthy case. Step 2. Port placement and initial exploration. Typically, 3 to 4 trocars are used, a camera port at the umbilicus or subxiphoid area, and working ports in the left upper quadrant and lower abdomen. A 30-degree laparoscope provides optimal visualization. The abdomen is insufflated to 12 to 15 millimeters mercury. After initial exploration to confirm anatomy and absence of contraindications, the omentum is swept downward to expose the spleen. Pitfall. In patients with prior upper abdominal surgery, adhesions may complicate access and visibility. Take care during initial dissection. Step 3. Mobilizing the splenic attachments. Dissection begins at the splenocolic ligament, which is divided to free the lower pole. The lateral peritoneal attachments, including the splenorenal and splenophrenic ligaments, are then taken down sequentially using an energy device. The gastrosplenic ligament, which contains the short gastric vessels, is dissected next. These vessels are divided close to the stomach to avoid gastric ischemia. A harmonic scalpel or ligature offers controlled hemostasis and precise dissection through these vascular attachments. Pearl. Carefully control the short gastrics to prevent bleeding near the gastric fundus, which is difficult to visualize later. Step 4. Splenic hilum dissection and vascular control. The splenic artery and vein at the hilum are carefully skeletonized. In most cases, a vascular stapler is used to transect the hilar pedicle en bloc. In patients with enlarged spleens or aberrant vasculature, individual vessel control with clips may be preferred. Intraoperative ultrasound or preoperative imaging can aid in identifying accessory spleens, which should also be removed if present, to prevent recurrence of hematologic disease. Pitfall. Incomplete hilar dissection or misfiring the stapler can lead to major hemorrhage. Always ensure full control before firing. Step 5. Specimen retrieval. Once fully mobilized and hemostasis is confirmed, the spleen is placed in a specimen retrieval bag. For smaller spleens, the bag is extracted through an enlarged trocar site. For larger spleens, morcellation within the bag allows piecemeal removal. Pearl. Always use a durable retrieval bag to prevent spillage and avoid contamination or tumor seeding. Step 6. Closure. The abdomen is irrigated and inspected for bleeding. Trocar sites 10 millimeters are closed with fascial sutures to prevent hernias. Skin is closed with sutures or adhesive, depending on surgeon preference. If a drain is placed, it exits through a lateral port site and is typically removed within 24 to 48 hours, depending on output. Post-operative care and recovery. Patients are monitored for post-splenectomy infection, bleeding, and pancreatic injury. Most are discharged within 1 to 3 days after tolerating diet and ambulation. Lifelong infection risk from encapsulated organisms is a key concern. Patients should be counseled on the need for booster vaccines and seeking care for fevers promptly. Pearl. Consider a medical alert bracelet indicating asplenic status for patients, especially those with hematologic conditions. Final thoughts. Laparoscopic splenectomy is a technically demanding but highly rewarding procedure that offers reduced recovery time and excellent long-term outcomes. With careful dissection, controlled vascular handling, and proper specimen removal, the procedure can be performed safely and efficiently. Thanks for scrubbing in with Ellie Scrubs In. Like and subscribe for more detailed surgical walkthroughs. We'll see you in the next case.